Okay, thanks.
Great.
Otherwise, we would have missed that recording opportunity. So, for those of you that just joined on today, we're going to be talking about virtual reality in vestibular rehab. But what I'm super excited about is that you actually get an opportunity to not only ask questions, but you get to meet Dr. Jennifer Stoskus. So, thank you all for joining us, and I would love, you've been on these before, I like to ask kind of start with that question of what inspired you to become a physical therapist.
Yeah, so I think about this a lot because one of the other courses I teach is professional development and leadership at a DPT program here in New Jersey. So I think what I wanted to do when I first heard about physical therapy was just to be able to help people get better. Coming out of PT school, going into PT school, I thought I was going to come out and become an aquatic physical therapist and work with geriatric patients, and that was going to be my niche. But I think what inspired my early career were working with patients with neurologic disorders. I think we all have some inspirational stories about patients that we've worked with. What inspires me now to continue in the profession is the ability to share and kind of not just share my knowledge base, but connect other clinicians with information that can help them help their patients get better, and network people together and connect the dots.
Great. And the internet really allows us to learn about people. So you and I, just recently have we gotten to know each other a little bit more, but our worlds have been parallel. Neurocom, I was a Neurocom user, did some clinical education training with Neurocom, and then I did some with Burtech. But what I learned about you, or I don't know enough, and so I would love for you to share, but it does seem like you were also inspired from some of your background in dance and theater.
Oh, yeah.
So I'm super excited to learn about that.
Certainly, yeah. So like most young athletes who become physical therapists, I was a runner, a swimmer, a dancer. I had some physical therapy on my knee, and that's kind of what brought me into learning about what physical therapy was. I think I knew I wanted to go to PT school when I was like a junior in high school. So I said, this is the profession. It's either go to school for musical theater or it's go to school for physical therapy. And, I was able to minor in dance during college. So I got my fix of the stage. But I think that's a big reason why I love doing clinical education. It kind of feels like you can come on the stage and interact with the audience just in a very similar way to being in a theater or dance production. Nice.
And you've already alluded this to a little bit, but you also, made the choice to become board certified in APTA and then neurology. So was there a particular population that you found the most interested? Like a lot of patients in the vestibular world came from the neuro world, either traumatic brain injury or stroke. So what was kind of your journey in that?
Yes. So my NCS, I started my career in outpatient neuro, really because I had my final 4-week clinical affiliation for my master's degree program was in an outpatient neuro clinic. And in 4 weeks, I got to be with pediatrics and geriatrics, and I did manual therapy for the spine because it was outpatient. We worked with spinal cord injury. We used a lot of technology. I did aquatic therapy. So when I moved home to New Jersey, I was fortunate enough to find an outpatient neuro practice that I got to dabble with a lot of those things. The other reason I wanted to go into outpatient neuro was because at Springfield College in Massachusetts, where I went to school, we had a stroke group exercise program. So I kind of say my first love in physical therapy was the stroke population. That was the population I felt like I had the most experience with as a student therapist. I really loved the idea of working in outpatient neuro. So my 5-year plan coming out of grad school, I said, I'm going to do my DPT, my transitional DPT, and I'm going to do my neurologic clinical specialist board certification, study and sit for that. And then I worked with, stroke, brain injury, and I realized that, part of the reason I got into vestibular rehab was not just the patient populations who had symptoms of dizziness or balance dysfunction, but I had mentors who specialized in vestibular rehab. So as I started working with this really broad neuro population, my mentors also said, hey, but these peripheral vestibular disorders, like look at DPT and make someone shake their head as they walk down the hallway and look at an object and throw balls back and forth. So at that 5-year mark, I said, I feel like I'm specializing in vestibular rehab. Do I really need to get my NCS? And then another year or two went by, and I had some conversations with some of my mentors from my master's degree program, some of my mentors in the clinic. And actually one day I was at a Sue Whitney course and I said, hey Sue, can I go out to dinner with you? Will you come to dinner with me tonight? And let's just have a conversation. And she sat me down and she said, okay, well, you're now 7 or whatever years out of school I was at the time. She said, if you want to do more with your career, you should just sit down and take the test. Just do it, right? You've been talking about it. You've been thinking about it. You asked some other people about it. And the tipping point was just someone saying, you've been out of school too long. Just do it. And actually it was great advice, because I was in a place in my career where I felt specialized in vestibular rehab, but we know there's no vestibular certification right now. Fingers crossed, maybe in our career time. But at the time I said, if I want to open some more doors in academia, maybe in research and some other things, I think those extra 3 letters at the end of my name will make a difference. And in fact, it really has. But I do think that neuro is kind of a really broad passion for me as well. So
sure.
So it definitely fits.
And was it during that time that you I will just ask, how did you become involved in the APTA, the vestibular edge, all the outcome measures? And it might help our listeners just to briefly explain what that is.
Sure. So the Vestibular Edge Task Force was a group of individuals who were selected to look at basically psychometric properties of outcome measures that we use in vestibular rehab, vet through the literature, read articles and articles and articles, come to consensus on what we could recommend as a group to be used. The origination of the EDGE, and I always forget what the acronym stands for, it's like the effectiveness database to guide something, some combination of looking at data to guide clinical practice effectiveness. The reason I got into outcome measures was because of my background in neuro, and really specifically stroke rehab, working with patients who had moderate to severe deficits due to a stroke, knowing that they were making improvements, but as a new grad, also realizing that range of motion and strength, or manual muscle testing, is not the outcome measure that's going to tell the insurance company that this person is getting better. So I started doing some of my own research into different outcome measurements, and at the time, this is probably 2010 or 11, the Academy of Neurologic Physical Therapy came out with the first EDGE group, which was the stroke EDGE. Mm-hmm. So they looked at outcome measures in stroke to guide effectiveness, or whatever the EDGE stands for. And really, I think that was when they had already been in process to start the multiple sclerosis EDGE group. but they put a call out for the vestibular edge group. And I said, I'm starting, this is like really early in my career. This is even, I think, before I went to the Emory course. I was really interested in vestibular rehab and I was really interested in outcome measurements. And I said, let me just apply for this task force. And I think that was really a pivotal thing for me in my career, kind of being really new and being a little green and being a little naive. And diving in with this group of experts to sit around and read through the literature and go back and forth to determine, what do we actually use in clinical practice? What can we recommend in clinical practice? What should we recommend more research gets done on, taught in academic programs? So that was a really great and probably an inspirational thing for me to join at the time. And I think that's when my career path really switched from neuro to really into that, I say vestibular concussion and balance disorder world.
Well, and just in listening to you talk about it, we'll for sure provide our listeners to a link of how you can access that information, because it's super helpful resource to have for those of you in the vestibular world. And so thank you and your colleagues for all your work on that. And also always like to ask in throughout your career, and you've already alluded to some aha moments and even being on this task force, how that transferred you from neuro to vestibular, but are there any other aha moments that you remember, inspirational, or some of my aha moments or the mistakes I made, that you would like to share?
Yeah, I think obviously I think that the Veg Task Force, having that opportunity was kind of an aha, that liking outcome measures and liking vestibular rehab could be a career path. I think sitting down with Sue Whitney and her just finally saying, just do the NCS. It's not an easy thing to sit down and study for, and then you apply for it, then you study for it, then you sit for it. But I think some of these critical times in my career path have been these aha moments. I've always loved to use technology in clinical practice. I was very fortunate that during that last clinical rotation in my master's program, I had lots of access to technology. I started at Kessler Rehab in Chester, New Jersey. We had lots of technology. We had a neurocom system. I was the one chosen to get sent to Clackamas, Oregon at the time for that training, right? So that was kind of like a pivotal point in introducing me and kind of having the onus to use technology in my practice. But one of the aha moments toward my last career change from working full-time in the clinic with Kessler to transitioning to full-time clinical education with Natus and the neurocom products, one of the things that I was really hungry for in the clinic was more technology, more metrics, more data, more outcome measures. I was at an orthopedic, pretty much an outpatient ortho typical practice at the time, and I didn't have space and I didn't have room for a dynamic CDP system, so I had a small force plate, and I just wanted more. I really realized how important technology could be in my clinical practice with my hunger for data and outcome measures. So having that transition to work with Natus and the neurocom product line, I think was also really pivotal in feeling comfortable transitioning from full-time clinic to full-time clinical education.
Well, and I think it's such a parallel, such a synergy between those two. How do you kind of follow it if you don't measure it? And that's a huge thing on the use of technology, is how objective the information can be. And you bring a unique experience to the table with your experience in like a static kind of force plate or the dynamic force plate with a larger neurocom, the CDP. and now Director of Clinical Education for Virtualis. And love to hear your thoughts on kind of that transition into more mobile, accessible, affordable technology and some solutions that it may offer. And not just, well, we're particularly interested in vestibular therapy, but
course,
really all therapies.
Yeah, and I think that technology, there's lots of, PTs are very resourceful as a group, right? The PTs that work with Dr. Nashner, who created the sensory organization test, Dr. Horak and Dr. Shumway Cook created the clinical test of sensory interaction on balance, the foam and dome. So I think there's always a place for low or no technology in clinical practice. But what I really like about working with technology from a clinical standpoint is that objective data, right? The hard numbers and the ability to track things really, really specifically over time. In clinical practice, the way that I teach my customers and my colleagues how to incorporate technology into clinical practice always starts with saying, this is not the only thing that we use in clinical practice, right? It's just to enhance what we do in clinical practice. And when I teach at Seton Hall University. When I teach there, I always tell the student, I do the lab for technology in balance assessment. And we always start by saying, PTs, our best resources are our eyes, because that type of visual, objective information, our ability to speak to a patient and ask the right questions, these are things that are the most important in clinical practice. The technology, if we have the eyes and the mouth and to be able to ask the right questions, the technology can help us along the way. So I like, head-mounted display technology, I think, especially for vestibular rehab, gives us the ability to do that extra step, that extra level of assessment that can really contribute to our bedside examination and our patient history.
And using the word assessment just reminds me as I get intrigued by asking more and more questions about you, is that actually ties into one of the questions that we received beforehand. So why don't we move on to some of the questions we've already received, and hopefully the listeners will chime in with their own questions as they hear you talk. So these are great questions. So one of them is there a difference between watching videos on a TV screen versus virtual reality?
And this is a very common question, right? So I think at the base of the question, we have to first define what virtual reality is. And anytime I do an educational course or program or talk about virtual reality, I think it's important to remember that virtual reality is any type of computerized environment or computer-made environment that a person interacts with that is made to make the person feel like the environment is real. The virtual environment is real, right? So virtual reality. TV can be virtual reality. I think a lot of us in clinical practice have used the Wii, or when it first came out, the Wii Fit. That is virtual reality. When a person is looking at the computer or the TV and they are interacting with it in a way that makes them feel like their weight shifting is real, or they're playing tennis, that is still virtual reality. So the difference between a TV mounted virtual reality like the Wii or like the Xbox Kinect and a head mounted virtual reality is something called immersion, how immersive the virtual environment is. And the other caveat is that virtual reality requires two things. It requires both the hardware and the software. So you can have the Wii Fit, that environment is the software, but the hardware doesn't allow the person to be interactive. It's just not, it's called non-immersive. Whereas if you put that same type of software into a head-mounted display, now it becomes fully immersive. So the difference between a TV and what people call virtual reality typically is the hardware. That tells us what type of immersion, if it's non-immersive, semi-immersive, or fully immersive. And then the software, how realistic the software is what we call presence. How well can we bring someone into the environment and really make them feel present in that environment? So for example, head-mounted display, you can turn your head in all different directions. Often head-mounted displays even have auditory cues or music or sounds. So one of the, a very basic virtual environment might be, we have the way we call it the relaxation module. You can choose a couple different environments. My favorite is the beach environment. And so you put the headset on and you are on a beach. And if you sit in your chair, you can see the legs of the avatar. You can hear the birds flying by. You can see and hear the ocean waves coming back and forth. And if you turn around, you see the rest of the beach or the rest of the ocean or the mountainside next to you. So the difference between TV and virtual reality is immersion and presence.
And so how does that compare with augmented reality?
Augmented reality. So the best example for augmented reality is the Pokemon Go game. Augmented reality uses technology to augment the real world in some way. So Pokemon Go, and I never played it myself, but the idea was that you basically turn the camera on your phone. So you're interacting with that two-dimensional non-immersive hardware, but you're seeing the real world, and the augmentation of the real world are characters, like the little Pokemons that you would turn your phone and look through your phone and see a character. Another example of augmented reality would be some of the furniture, like Wayfair and Overstock and some of these furniture companies, where you can kind of take a video or a picture of your physical house, your physical space, and augment into that space where the couch would go, or the carpet, or the recliner. That's another way to use augmented reality. All
right, thanks. Of course, that was a question that I kind of skipped down, but it was perfect timing. So,
yeah, sure.
Another great question. Is there a screening tool to identify if a patient will or will not tolerate virtual reality?
This is another very common question that I get from my customers. And I have two researchers working on this question right now. Is there one screening tool that is kind of universally accepted? I think the answer is no. But there are a few different ways that we can screen if someone might be appropriate. And I'm going to go as far to say to wear head-mounted display or immersive virtual reality, right? Because can someone watch a TV screen? That could be a question. But when we think about immersive virtual reality, I'll also define some of the contraindications and precautions for using head-mounted display. I think we also need to say that virtual reality is a tool that we use in rehab. Again, so you're not going to put someone in virtual reality. It's not going to do the thing for you. So the therapist, the operator, is always applying virtual reality to the patient, number one. Number two, we have to think about precautions of using virtual reality with any population, just like we think about applying any technology or applying any tool to a patient. So similar to eSTIM, we think, does the patient have a precaution or contraindication when we apply it? Women who are pregnant, we worry about if they can't see their environment and we're testing their balance or treating their balance, are they appropriate? Of course, like anything else in the clinic, we check with their providers first. Young children, same thing. If they're very young, we check with their, referring provider if it's safe to use it with them. Individuals who have epilepsy or seizure disorders, we check with the provider, right? There's no, no necessary hard and fast contraindications. These are things that we consider as precautions, and then we consider how we apply virtual reality to the patient.
Okay, this is my own question after hearing you, explain that is, and because you're also treating patients with 3PD,
Sure.
the literature does show this decreased sensory reweighting, where maybe it's an over reliance on vision and an under reliance on somatosensory cues. So they're not tapping into their somatosensory system. Do you find when you have used virtual reality that the patient suddenly has to tap into somatosensory because this is different? Do you find that to be a beneficial tool for not just dizziness, but actually promoting the use of somatosensory cues?
Yeah, I think one of the benefits of using virtual reality is the ability to help someone reweight the sensory information, right? And so we do that a lot by providing visual information, either conflicting visual information or strong, colorful, bright, maybe dynamic visual information, complex visual information, and then teaching them to decrease their reliance or ignore the vision and rely upon another sensory system like somatosensory. I think, I'm gonna go back and say we need to measure first what is the function of the patient's sensory systems and give a quantification of how well they're using them first before we apply a treatment for sensory reweighting. And we do these things in the clinic as well. But when we assess, so we'll use 3PD as an example. And I agree. I think the theory is these individuals are overly reliant on vision and vestibular. Their brain is listening to the vestibular system and not kind of ignoring it. And they're not listening to somatosensory cues, which should be the number one thing the brain listens to in a perfect world when somatosensory information is accurate and available to us. So first we want to look at, the way that I think we typically look at sensory contribution to balance is through some level of sensory organization test, clinical test of sensory interaction on balance, or a modified version of that. We also want to know about someone's vestibular function, the other portions of the vestibular function. So if the vestibular system is responsible for sensory contribution to postural stability, right? Balance, sensory organization, gaze stability. We want to assess some level of dynamic visual acuity, gaze stabilization. And then the third function is that perceptual orientation or spatial orientation. And I think that's something that we don't have technology for in the clinic very often. Maybe the bucket test, maybe a hard bucket if you created your own hardware for that. But something that virtual head-mounted display virtual reality gives to us to assess that perceptual orientation is the subjective visual vertical. Dynamic subjective visual vertical, sometimes called the rod and disc test. And then a test for visual field dependence called the rod and frame test. We can put someone into this immersive environment that is very disorienting and ask them, if we take away somatosensory system information, we make the visual information very disorienting and immersive. Can they rely upon vestibular cues to determine which way is up? What is vertical?
So are you doing that? Oh, go ahead.
I was just going to say, so when we can assess that level of where they're starting with, what's available, what's working for them, what's not working for them, then we can give that sensory reweighting, whether it's visual, ignoring visual information, progressing a complexity of a visual environment from basic to complex or static to dynamic, or using the information for some other to improve the function of other systems.
Well, and I think and I am certainly guilty of this, of thinking of virtual reality so often as a treatment tool versus an assessment tool. So I think it'd be helpful just again to review some of, you already have, but maybe just a broad overview of the assessments that can actually be done in the goggles.
Sure, yeah. So our assessments specifically are broken down into assessments for vestibular function and balance, assessments for functional things like range of motion. We have assessments for visual neglect, as well as other neurologic dysfunction. And that's just in the head-mounted display. We also have full posturography, so static force plates and also a motion simulator dynamic force plate. So when we think about vestibular and balance assessments, again, we think of the three functions of the vestibular system. So postural stability or balance, we're assessing things like the sensory organization test, on our motion simulator. We're assessing our clinical test of sensory interaction on balance, all 6 conditions on the static force plate, or just on the regular floor with a piece of foam with the head-mounted display, taking the sway velocity of basically of the head. So postural stability, we assess through that. We also assess gaze stability through the dynamic visual acuity test, right? Perceptual orientation through subjective visual vertical, rod and frame, and dynamic subjective visual vertical. Then we, with our force plates, we test automatic and adaptive voluntary motor control. That would be for that motor side of balance, not just, balance is not just vestibular, it's sensory and motor. And, of course, things like adaptation test, motor control test, limits of stability test, a variety of other kind of motor related assessments. For the functional assessments, just with the head mounted display, we have a range of motion test. So a cervical range of motion. We also have a cervicocephalic relocation test, which is commonly referred to as the joint position error test, looking at proprioception of the cervical spine, and upper limb range of motion. So kind of a not goniometry of the shoulder, but functional range of motion of the shoulder in a standing position.
And does that require use of something on the hands, or what picks up the range of motion?
So the hardware that connects with the software are hand controllers. The patient would hold in their hands, and the software tracks where those controllers are in space to get the range of motion of the shoulder.
And is there anything available for lower extremities?
It's not released, but in development is a hip range of motion. And then, of course, all of our assessments have kind of rehab modules that are associated with them. And so we'll have hip range of motion, I think, potentially coming soon. But certainly with the hip range of motion would come hip retraining, very, very orthopedic based kind of exercises for treatment.
Okay, I know you love outcomes, so
yes.
I had to ask you about the assessment plus. Again, it was a question. Okay, in your opinion on the use of virtual reality what is occurring? VOR adaptation versus habituation, and does it even matter?
So the question, I think, needs to go back to defining what virtual reality is. VOR adaptation versus habituation. I think so I think, Bridget, you and I had this conversation a couple of weeks ago. When I talk to non-vestibular therapists, I use the same terminology that I use with vestibular therapists, right? So in vestibular rehab, we work on 3 things. We work on adapting whatever function the patient has left, making them stronger, right? VOR adaptation, making that VOR, that reflex stronger. We work on habituating making their essentially in their endurance better to whatever activity it is. So we make them stronger, we improve the endurance once they're stronger. And if we can't do those two things, then we compensate or teach them substitution, right? So we do this in vestibular rehab. We also do it in all, this is how all of rehabilitation works. So when we use virtual reality, right, as a tool, when we apply it to our patient, we still need to figure out which of those areas of rehab of motor learning, what are we focusing on? So we have a DBA, we have a VOR retraining module. And in order to adapt the VOR, we need a person to look at a thing and turn their head. So our software has, we have actually a few softwares that can accomplish that. Look at an object and turn your head to try to make this, to stabilize the gaze, to adapt the VOR. I think a lot more of what we do in virtual reality could be habituation. Show someone an environment and then give them small doses and build their endurance. And I try to teach my customers, this is like what we do with treadmill training, what we do with aerobic conditioning. We get someone to go until they're tired or symptomatic, then we rest, and then we habituate them to whatever, whether it's a task or a visual environment. But it could be either of those, because we have a balloon popping module. So if you want to get someone's arms stronger, from an orthopedic capacity, you're going to add a weight. You're going to adapt their ability to do it, and then make it harder by increasing the resistance. If we want to do it to just build their endurance and make it an easier task, maybe we're habituating them to the activity of reaching. If we just set 2 balloons, because we can, ideally virtual reality in our system specifically was developed by our CEO is a vestibular physical therapist. So he wanted full control over the environment. He wanted to be able to track someone's performance and make it easier or harder. So we can have a lot of balloons. We can just set 2 balloons and make someone turn their head to tag one balloon, turn their head, tag the other balloon. So to make it more of a VOR type of an activity or a gaze stability exercise.
And can you, with the headset, can you have audio in there of what velocity they would move their head?
We do have so not all of our modules have a metronome. And mostly we're not having a person turn their head, right? So I keep my post-it notes here, right? I'm not saying turn your head and keep an object still on the screen, although we do have the capacity for that. Most of what our VOR adaptation activities are functional. So turn your head, did you see the letter or the word appear? Can you identify it? And then input their answer, either teach the patient to input their own answer, see the answer, get some motor learning, get some kind of adaptive learning in the session, or the therapist or someone else could be putting their answers in. So I would say most of the adaptation for gaze stability is more functional in nature. Okay.
And I think this is a great time to ask this question, because my mind starts thinking, when you think function and then movement, is how much space do you need to utilize like the Virtualis, or is it just in a small area? Do they need to be able to move around?
It depends. I think we recommend a 10 foot by 10 foot space, and that is. We have a computer stand, like if your Neurocom and your Vertex system has a computer cart, computer stand. And then we also want the patient to be able to, like I mentioned, pop the balloons, right? So be able to reach their arms and do a reaching activity. Instead of the hand controllers, we might sub out the controller for a tracker, and maybe put the tracker on someone's foot. So instead of popping balloons, they're with their hands, they're kicking balloons with their feet. or, one of the other modules. So we want a little bit of space, for those types of activities. We also have environments, right? So virtual environments that simulate the real world. We have a grocery store, so our supermarket environment. We have a crowded environment. We have a pedestrian environment where you can walk through the grocery store. So you want some space to be able to have your patient walk, maybe walk unrestricted for that, or the subway, walk, step onto the subway car, turn around and watch the subway go by. Or one of my favorite we call them the crowd environments, is the pedestrian environment where they can walk across the street. Now they can walk to the edge of the sidewalk, turn their head both ways, look for the pedestrian sign to flash to cross the street, and then they can take steps across the street. So the space requirements really are only based on, if you're going to use more of those immersive, crowd environments, or the supermarket, the grocery store, the shopping mall, you'd want a little bit more open space. Some of our customers who are really most interested in the assessments, you don't need that much space. You just need enough space for a computer cart, your body to guard the patient, and then the patient's body.
Okay.
So
and is it Bluetooth? Is it Bluetooth, or is it a cord attached to the computer?
It is a tethered cord.
Okay.
And the caveat is because so there was an earlier question about, how do we determine if someone's appropriate for virtual reality? We want to know something about our patient's motion sickness tolerance, or their visual, the VVAS, the visual vertigo tolerance, their tolerance to busy and moving environments. When we don't have a tethered cord, when it's a Bluetooth type of a signal, a wireless signal, we have a lag in time from when the signal goes from the computer to the headset. And that lag is what could potentially make people virtual sickness, right? Give people virtual reality sickness. So if you're playing virtual reality at home, oftentimes even normal functioning or neurotypical, or people who have strong vestibular systems and good sensory processing, can still get virtual reality sickness if the hardware and software connection has a lag. It's just like in the real world, I turn my head, my environment is not moving, so I'm getting real-time feedback of my head in space. When we use a tethered cord to the virtual reality headset, that reduces that lag. So it's imperceptible.
Okay.
Now the hardware is almost there, and our CEO will not change the hardware until he knows that the technology is good enough, because his initial goal of creating this software was to help his patients with motion sickness.
Awesome. Yeah, that makes perfect sense. And it's interesting to look at some of the literature about the estimated increases in as we begin to use virtual reality, how many people will actually have that virtual sickness. I'm curious, is there a particular scale? You did just mention I think you mentioned the vertigo visual analog scale.
Yeah. So, and I think this was a question earlier. I never really answered it because I talked about something else. But this is one of the research questions. So this is a question that customers ask. This is a question I have some researchers working on right now. We don't have one, kind of universal measure to determine if someone's appropriate for virtual reality. The measures or the questions that we want to know answers to are going to relate to more or less relate to what we want to do with them in virtual reality. I think most people tolerate assessment. I think if they're migraineurs, if they have visually induced motion sickness, if they have these sensitivity to the visual environment or self-motion, I think they can tolerate assessments pretty well. It's the question of when we prescribe treatment, what will they tolerate and where do we need to start our dosage, our prescription, our application? So the visual vertigo analog scale is a good place to start, but just because someone has visual vertigo or they have visual environment motion sickness doesn't mean that they're not a candidate. You just need to know that you have to start them, I say, seated, slow, short duration, right? So lots of somatosensory information, really short doses, whatever you do, whether it's a static environment or a dynamic environment. You start them, I think, in your talk last week on optokinetics and those populations, we can start as low as 10 seconds. That's okay for some people. And then if we're doing a dynamic environment, we're not going to make the dynamic environment go quickly. We're going to start the dynamic environment slowly. But the other types of questionnaires we see is the Kennedy simulator sickness or sickness simulator. That was developed for NASA back in the, I think, 70s to just, it's like the post-concussion symptom scale where you rate your symptoms pre, and then you do with some simulator or virtual reality, and then you rate your symptoms post. And it's just a way to track someone's symptoms.
And I can share that with our listeners. You know, we just initiated that with our new kind of MDDS protocol.
Yeah.
And it doesn't have points attached to it. So we added a numeric scale so that we could get a score, and we have them do it before and after. So we just started using actually that same scale.
Yeah.
Okay, so you answered the question about space. You actually just answered the one about progression, seated, standing,
Sure,
again, duration. The patient defines that.
Yeah.
Here's a question. Do you have patients use virtual reality as part of their home program?
I personally do not. And Virtualis as a company has been looking into a home-based system, but there are a few things to consider when and again, we're going to define this as using a head-mounted display virtual reality system at home. The things we consider, number one, and we've learned this in the last couple of years with telehealth, is that our number one priority is to keep the patient safe, and we're not physically in their space. So when we're doing telehealth, I often say scan the room and make sure the dog and the cat are in the other room. So they're not going to, walk in front of you. They're not going to be a tripping hazard that I cannot see on the other side of the computer. So I think when we put someone in immersive virtual reality, the goal is that they forget about the real world. But the risk of that is that they may step, trip. I mean, I'm guilty of, in my home office here, when I use our system and I'm practicing certain things, I've punched my desk and my computer more than once. and that's the goal of the virtual environment being so real that you forget about your surroundings. But the risk of using it as a home program is that we need to consider our patient's balance and our patient's safety. The other thing to consider is the ability to prescribe and dose our patients. And we all know the patients. So we have patients who may not do their home program very often, but we also have patients on the other end of the spectrum. You tell them to do, 15 repetitions of a bridge or a squat, and they go and do 50 because more is better. And then they can't walk the next day, or they do their ×1 viewing, or they do their VOR adaptation exercises, and they do too much. And so when we put someone in a virtual environment, especially when we're working on habituation, we don't want them to be able to go too far too fast, because we know that they can make themselves sick if they're not prescribing the environment appropriately. So we're thinking about, we're working on, is there a solution where we can have the therapist set the speed, the duration, the opacity, the activity, however long the patient should do the activity for. And then maybe if the therapist can set it, then it could be safe to be prescribed at home. But the other consideration is always the safety of the patient. So when I
Sure.
teach my customers and I say, all right, I provided your training. Now you get to go and practice on your own for the next couple of days or weeks until you put this on a patient. When I tell my customers to go practice, I absolutely say, practice in pairs because it's safer. You never want to put yourself, and when I'm in my home office, I always tell my husband, if he's in the other room, I make sure that someone knows that if they hear a loud crash, come into the next room and check in on me. Or I clear my space, because that's one of the risks of using a virtual head-mounted display system at home.
And speaking of, so safety, and you talked about, those small dosing. Do you tell your customers there's an average time that they may spend with their patients, like as part of a treatment session? So,
Sure.
a lot of therapists, they're overwhelmed to start something new. There's the demands of paperwork, and it's like, I have to learn something new, and they want to know, well, when am I going to use it? How long am I going to use it?
Yeah. How long does it take you to set it up? How long is it? Yeah. And again, these are things, and I've been teaching technology for a couple of years now, teaching people how to incorporate it into their clinical practice. Always take your time, right? Because we can bill for the setup, the instruction, the thing that we do with the patient, and then the breakdown and kind of the recap with the patient. We can bill for all of that time. So take your time. Our Virtualis software was created by a PT with a team of PTs and OTs to say, we know we're busy. Let's be able to click enter, pick the patient. The way that our software is set up is you choose assessment or rehab. And then once you're in assessment or rehab, you go into this, whichever impairment category your patient's in, and pick the exercise that's appropriate for them. We dose like we dose any other exercises. You're either looking at the repetition that the patient's performing, if that's the goal, or you're looking at their accuracy from a motor learning perspective, or you're looking at the duration of time from that habituation perspective. You go, depending, if we're working with vestibular patients in habituation categories, we're dosing to tolerance. We're letting them rest and helping them to actively recover out of the virtual environment. I think you use the box breathing. You take them out of the headset, you sit with them, and you help manage their symptoms, and then you put them back in for a few minutes, and then you help manage, right? So we dose it like we would dose in the clinic: repetition, time, symptom tolerance. Total time. You could do an hour of that with a patient, but we don't, but technology is a part of our clinical practice. It's not the whole clinical practice. So, 15 minutes, 25, 30 max. We don't want anyone in the head-mounted display for 15, a total time of 15 minutes. So we always take them out of the headset. We explain, we explain what to do. We put the headset on, we do the thing, we take them out. We tell them what they just did. Then we tell them what the next exercise or assessment or whatever we're doing. We put them in the headset, we do it a few minutes, and we take it out, take the headset off, and then do the next thing, just like we would do with exercises in the clinic. So 15 minutes total time in one individual module, but total time of your treatment session, it'll be about a quarter, no more than a half of your treatment session, I think, because we invite the patient in, we talk to them, ask them, we do something, maybe we take a measurement, maybe we do some treatment, then we educate them on their home exercise program before they go out the door. So we want to always save some bumpers on each side of that.
And would a clinic typically have, obviously this would depend on size, but one pair or two pair? I was actually thinking about this question with COVID, or do patients seem more paranoid about wearing something? How is that? How do you address that with customers?
So in terms of cleaning, right, before COVID, we have changed out all of the headset. Anything that touches the patient's face, skin, or head is wipeable.
Okay.
So from a cleanliness standpoint, they also make, right, you can also put a bouffant cap, a surgical cap, a hairnet over the patient's head for an extra layer of protection. You can also put a paper mask inside for an extra layer of protection if they need. So that's the cleaning standpoint. Some clinics do have two systems. It's mostly because they want their dynamic system with a headset in this corner, and then they want their just standalone headset system in that corner. So that's the motion VR system and our physio VR system. So that some clinics have two systems just because they want to do different things at the same time.
Yeah, and I can definitely see, you know, volume. I'm thinking, you know, if I'm sure if with several therapists, they would all want to be implementing that. So
Yeah.
we are closing in on the hour. I don't see any questions yet, but I'm going to ask you a question and I'll monitor here to see if
Sure.
anyone has any specific questions for you. When you were talking about, you know, the small dosing, and actually that was one of my questions, do you take them out of it? So you take them out of it, and, you know, you and I talked about, like you said, the adaptation, habituation, and substitution, but we also talked about recovery. And, you know, we obviously know we have to educate our patients that we're moving a little bit into symptoms and we want to stay there for a little bit. How much do you talk about recovery with your patients and or when you're educating your customers? Like, do you have a guideline about how quickly they recover?
I don't have a guideline, but I think that we think about recovery like, you know, I think we're specifically talking about patients we're using habituation with, right? But it's the same with pain, it's the same with weakness, it's the same with muscle fatigue. We want to not just let the patient sit, we want to help them recover by doing active recovery techniques. So, you know, in our software, we have a relaxation module that could be paired with breathing if they have anxiety or high symptoms, and we want to want to distract the brain to do something different. But I think the goal of recovery is not just a length of time, but it's the ability to use it as an educational opportunity to help the patient actively recover, however that might be. I use, you know, me personally, I use body scanning. I use breathing techniques to help their brain go from symptom brain to thinking about, you know, focusing on something else at the time.
And I'm glad you mentioned that because I have been following the research, and there's a notable amount of research on stress management, the use of virtual reality for anxiety, and it's quite promising. So thanks for mentioning that. All right, I don't see any questions, and I could just sit here and pick your brain all day. So we may get some. Let me check the chat.
Sure.
Yeah, I don't see any, but thank you for your time. We may get some post questions. You know, we had received so many before today's talk that I think that gave us a great opportunity to address what you said were even common questions that you get.
Absolutely.
This was a great learning experience for me. It's always an honor to talk to you, and I look forward to the next time we get to do something together.
Likewise, absolutely.
All right. Thanks so much, and thank you to all of our listeners, and we'll see you next time.
Bye, everyone.
Bye-bye.